going to be okay? Sit him on. Good afternoon. Oh, that's so much better. I could use my mom voice if I didn't have this, but this will be better. I wanted to welcome everyone back. If you've finished your lunch and you're filing in, CMS cafeteria is actually pretty good, so I hope you enjoyed your lunch. I enjoy it. Yeah, it's pretty good. This morning was really wonderful. I enjoyed every minute of it, and I'm so glad our panelists could come. There's a lot for us to digest, but I think it was really, really helpful, and we have 2 more of the 4 areas that we, the agency, have been looking into this afternoon, including Alzheimer's and related diseases, which is our first panel up here after lunch. I wanted to go ahead and introduce Ellen Blackwell, who is a senior advisor in our Center for Clinical Standards and Quality in the Quality Measurement and Value-Based Incentives Group. And in case you can't tell, our moderators come from all different areas here in the agency, and that really started because of the amount of coordinating we need to do internally to really look at addressing these topics. So let's welcome Ellen up and the wonderful panel we have coming.
Thanks, everybody, for coming today. We have a terrific group of people at CMS who are very dedicated to issues related to Alzheimer's disease and dementia, and I co-lead those efforts along with our Deputy Chief Medical Officer, Sherry Lang. So we're absolutely thrilled that our CMMI colleagues are willing to talk about a potential dementia model. So we have a wonderful panel with us today. Our first panelist is Dr. Malaz Bustani. Malaz is the founding director and the chief innovation and implementation officer at the Sandra Eskenazi Center for Brain Care Innovation at Indiana University. Our second panelist is Martha Rorty. Martha is the executive director for the National Association of States United for Aging and Disabilities. I typically say NASHWA, so I did read the whole thing today, Martha. Martha is an expert on home and community-based services and Medicaid. And last, Lynn Feinberg, who is a senior strategic policy advisor at AARP's Public Policy Institute. Lynn is also a national expert on caregiving and aging issues. So we are so fortunate to have these wonderful people who've dedicated their careers in part to Alzheimer's disease and the people that have it and their families. So Malaz, I'm going to kick it off with you and let you tell us a little bit about your work.
Thank you, Ellen. Thank you very much for CMS and CMMI and the National Institute on Health. These 3 federal agencies have helped us a lot in discovering solution and make sure they don't stay on the bookshelf. So that's my goal for you, is to share our experience regarding scaling up, implementing, and distributing an evidence-based collaborative care model. So building on what you heard already in the past couple of hours, but specifically for people suffering from Alzheimer's disease and related dementia. The work that I'm presenting with you has really been collaboration with my mentor and professor from UCLA, Dr. David Rubin. We've been working together now for the past 10 years. And I'm going to share also with you data from other investigators across the country. Some of them are already over here locally in Johns Hopkins, and some folks are in University of California in San Francisco. So this is the problem that everybody know. This is very conservative estimate. There's 3 million people with Alzheimer's disease-related dementia. Some people argue it's maybe 5 million people. And these folks are not only suffering from cognitive disability. They are actually suffering from behavioral and psychological symptoms related to their underlying dementia on top of their functional problem. And these 2 disabilities, the functional, behavioral, and psychological disability, not the cognitive, are main contributor for them to being visited in the hospital inappropriately, emergency room, leaving their home, on top of the caregiver stress. The other piece I want to mention over here, I use the word family caregiver or unpaid caregiver just to differentiate. When we say caregiver here, we're not talking about care providers. These are usually family, spouse, who are providing the majority of caring and coping with these disabilities that these patients are suffering from. And this disability, these cluster of these disability affecting the quality of life, not just for the patient, but also the family or unpaid caregiver quality of life. It leads to higher emergency room visits, hospital visits that are inappropriate, not just for the patient, but also for the family caregiver, and make them end up leaving their home and going to the nursing home and switching from paying for maybe $500 a month into paying $5,000 in a place that I do not want to go to. So that's a big thing. And depending on how you calculate costs, the cost for the patient with dementia, not including their caregiver, can come over all the way from $41,000 to $56,000. If you look at CMS in particular, Medicare, that cost might be actually around $13,000, sometime up to $24,000, depending on where you are. This problem is not just unique for society, it's very personally for me. My family are at very, very high risk of developing Alzheimer's disease-related dementia. So if we don't figure this out, my family will be in trouble, and I bet a lot of you guys' family are at high risk. So this is real personal for all of us over here. Now I'm going to give you a little bit solution. So the solution, it's been going on now. We know this solution exists that is evidence-based at least since 2003. This solution is built on what you already heard. This is an evidence-based collaborative care model, similar to depression, but here we have uptaken and modified it to meet the need of patient with dementia. This is more of a system solution. What you see over here in the middle, this solution requires the presence of scalable dementia care coordinator team, not just provider, a team. And that team will have access to and provide solution for the unpaid family caregiver who usually live in the community and work with them on counseling them and self-managing the caregiver. And also connect with a specialty place or consultant or medical care, usually in memory care practice or mental health providers. They work directly with primary care provider as a main provider for these patients, but they don't stop there. They go all the way to the community-based organization like the Area on Aging. And constantly while they're doing that, the collaborative care model require objectivity of fixing access, coordination, and monitoring that you're responding to the need of the patient and the caregiver. The principle of collaborative care model, you have heard of it already. I'm just going to re-emphasize it and highlight it again. It's a population-based care. It's not just individual-based care, it's population-based care. It's very objective. We call that measurement-based treatment to target. So for example, for us, we have something called Healthy Aging Brain Care Monitor that measure the level of problems that the caregiver struggle with, the cognitive, behavioral, psychological, and functional disability, and looking at that number over time and make sure it go from the red zone to the green zone. Very similar to the PHQ-9 that used in people with a major depression. Is very patient and family-centered collaboration in dementia. In particular is the family, and it's evidence-based. The content of these protocols are evidence-based. And finally, there's a big concept of accountability. Without it, everything else, I think, will be losing fidelity over time. The evidence to back me my statement that this is evidence-based collaborative care model is the following. Number one, we started building on the shoulder of the collaborative care model that was developed for depression. There's literally at least 50 randomized control trial. Some people think it's almost 80. And then for dementia, there is already 4 randomized control trial to show that this model of care have reduced the burden on the patients and the family, and maybe even sometime the healthcare system. There is 2 academic health centers that have actually converted collaborative care model to a clinical program. For us in Indiana, and I know in UCLA, and I know in Johns Hopkins are working on converting their innovation award into a clinical program. And now, through the support of CMS Innovation, there's 4 completed or ongoing demonstration project to test some type of the collaborative care model for dementia. UCLA and IU, we were in the first cohort. Johns Hopkins, UCSF with the University of Nebraska are in the second cohort, and I think they are almost in the last 6 months of their project. Now, here is the minimum standard of the collaborative care model based on these four clinical trial and the depression clinical trial. Number one, you need to really create a practical, reliable tool to measure the biopsychosocial needs of the patients and the caregiver. Number two, after you measure their need, very simple, you need to create dementia care plan for that one, and then you're going to have to start implement, which is the big source of complexity, implement a bunch of psychosocial intervention and medical intervention within the care plan to really reduce the burden driven by the cognitive, functional, behavioral, and psychological disability, not just for the patient suffering from disease, but their family. Then that type of navigation in healthcare system and community-based organization going to need require support to help you navigate that system. It also it has some evidence-based prescribing patterns. So if you have Alzheimer's disease, there's some medication that can reduce the symptom burden. But the other piece of it is there's something called deprescribing, and you heard that from when you heard about substance abuse disorder, that a lot of the substance abuse disorder provider are more of a deprescriber, stopping these medication, and this is also part of the evidence. And then people with dementia don't suffer just from dementia. They have other syndrome on top of their dementia, and there's protocol how to manage major depression on dementia, how to manage generalized anxiety disorder on dementia, delirium on dementia. And then these patients with dementia, their loved one, they are ping pong in transitional care between nursing home, subacute, long-term, hospital, community-based organization, and that require coordination. And then sometime we have to go to the patient's home and modify their physical and social environment to allow them to accommodate and cope with the disability of their underlying disorder. Now, I shared with you the solution, the evidence-based solution. If you have asked me almost 7 years ago, what would you have done? I would have told you, that's it. I found the solution. It's been replicated by Hopkins, by UCLA, by others. It was built on Jürgen Unitzer, and my job is to publish it in JAMA, and then everything will work. I thought that's how things work out. This is how I get judged as a professor in my school, but what I found out that actually that's not true. You have to make sure your solution is scalable, especially if you are thinking about mass distribution of the solution. But there's 3 other steps that I completely underappreciate. Because I thought if I'm a good doctor, a good scientist, I can simply become a great business guy. Apparently, that's not the case. So there's something called packaging of your solution. You have to find distribution network of your solution. And besides, if there's no market demand on your solution will stay on the bookshelf. And that's what I didn't know. So based on this new knowledge that I became aware of 5 years ago, other people have been aware of it since they were born. So based on that, here's the opportunity that I think we can build on the collaborative care model. I think right now CMS has been amazingly building a lot on this transition from volume-based to value-based. This program called Quality Payment Program, I think we can use it to create a market demand. I think we can use it to create market demand. How can we do that? It may be most likely a combination of advanced alternative payment model, building on what CMS have already done with CPC Plus and others, and merit-based incentive payment system together. I think we can create a market demand. And here's my first draft of the solution that I'm hopeful that all of you join in and modify it and we can make it to the finish line. So what I think we can do, I think the collaborative care model codes that already exist for depression, it's awesome, but it's very hard to implement. It requires a lot of pieces. My suggestion is to create more of a PMPM or per member per month type of patients payment for patients with dementia, that you can do it on top of their already paid fee-for-services, but take away any transitional care codes, chronic care codes, cognitive impairment codes, and build on it. And you don't just stay there, then you need to work on creating a merit-based quality to make sure that they are doing what they're supposed to do, or at least implementing the evidence-based collaborative care model for dementia. So that's technically my suggestions for you. Again, this is the beginning of conversation. If you want to join us, here's my email. I know a lot of other folks who want to figure this out together, so at least the 3 to 5 million people with dementia will be able to not move to Indianapolis or UCLA or Baltimore to receive evidence-based model that we discovered in 2006. So it's just not fair. Thank you.
Malaz, thank you so much. That was a great start to the conversation about what exactly we need to do and what we need to build into a model for people with dementia. So Martha, I am now going to turn it over to you and let you tell us what you think.
Okay, thanks. I don't have to go that high energy after lunch. So I'm Martha Rorty, as it was said, and I am the Executive Director of the National Association of States United for Aging and Disabilities, which I hate that acronym very much. It's one of the worst decisions of my life to name it that. Our association started over 50 years ago focusing on just aging, and we were born before actually the Older Americans Act was started. But as our members' responsibilities increased, they took on the portfolio of disabilities and long-term services and supports Medicaid, so hence the name change. What I want to share with you is that we just recently did a survey of our membership to ask them what their top priorities were in their leadership and what are they focusing most on. And many of these overlap with what we're talking about in terms of Alzheimer's and related dementia and how we're going to fund them. The first is ensuring compliance with the HCBS settings rule. The second is adult protective services, and whether we like to talk about it or not, a lot of incidences of financial abuse and physical abuse are actually happening at the hands of caregivers that are exhausted from caring for people with dementia. Improving the quality of services across the board, the movement and migration to MLTSS, implementing the long-term care ombudsman regulation, which works with nursing homes and assisted living to ensure that there's somebody there to facilitate a dialogue if there's a problem, addressing senior hunger and food insecurity, and then services for individuals with Alzheimer's and related dementias. One of the interesting components also of our membership is, in addition to taking on physical disabilities and the Medicaid long-term services and supports program, nearly 50% of our members are also now responsible for the population that have intellectual and developmental disabilities. And they're at increasing risk of developing Alzheimer's and related dementia. So this number 7 is actually bucketed multiple ways because the services for people with dementia that also have IDD becomes even more of an issue. And the family caregivers in many of those instances are their parents who are in their 80s. So we technically have at least 2 people that we're caring for. There's really 3 federal financing programs that are supportive of the Alzheimer's care, and supporting Alzheimer's care. There's Medicare, which, as you all know probably, it doesn't support institutional setting care. A lot of congressmen and senators don't appear to know that. So I make it my public service announcement that it doesn't. And it doesn't pay for in-home care for long-term periods. It does for post-acute care. It will pay for some things, but not for long-term situations. Medicaid is based on both a functional and financial eligibility, and it varies state by state. So if you've seen one Medicaid program and you understand how it operates, that's what you've seen one. But it will pay for nursing home care, and it will also pay for home and community-based services under waivers in most states. And then the Older Americans Act program, everybody in the United States that's over 60, technically you're eligible, which is always kind of silly when you think about people like Bill Gates is eligible for a home-delivered free meal. Right? That's kind of silly. But it really, we don't have enough funding to even meet any of the targets. But the Older Americans Act does provide a lot of services, could provide even more if we had additional funding. but currently it's based on specific targets that are set at the federal and state level. That was interesting how that transitioned. So we all know that the average cost of care is, and most individuals, as the doctor shared, would prefer to be receiving care in their home and communities. We have data in our on our website that I'm sure you can look at. But this shows kind of the national median average, not segregated by Medicaid or private pay, but how much things cost versus home health versus nursing home care. You can see pretty quickly how if you are paying for this on your own without long-term care insurance, how you can quickly deplete your resources and fall into being an individual with Medicaid. In fact, the New York Times wrote up just recently during the healthcare debate that Medicaid no longer is just an issue for the low-income seniors to be concerned about. It's really about the middle-income individuals that don't have any type of other long-term care insurance, that they quickly can fall into this. Even if you're paying for 4 hours a day, which is the minimum, at least in this area, of having private homemaker help, that's $25 a day, or $25 for each hour for 4 hours minimum, usually 5-day requirement. So I don't know about you, but most of the people that I know, they don't have that extra pot of money just sitting around in their budget preparing for this. So the average annual cost for individuals that have dementia with Medicaid is actually higher than those without Medicaid. And why is that, you ask? Well, the next slide is really telling, and it's really because by the time people get into the Medicaid program, they're sicker. And they have additional chronic conditions. I think it's really important to note that it is, as you said, dementia isn't just that you have lost your memory. Usually individuals with dementia have multiple co-occurring disorders that underlie, they could have other things in addition to the anxiety and depression. They could have hypertension, they could have diabetes, et cetera, and those conditions worsen because they don't remember to take their medication. They don't remember to do the things that help to maintain their health. So the Older Americans Act, if we look at those as a three-legged stool, so there's Medicaid, Medicaid, and the Older Americans Act. They actually were all three part of the Great Society, and the Older Americans Act was signed 2 weeks before Medicare and Medicaid. And the hallmark of the Older Americans Act, if you haven't had a chance to read the legislation, okay, how many have? Nobody? I know. Oh, see, good. Yay! It truly is the preamble is one of the most beautiful acts you'd ever want to read because it is all about what the ideal would be for home and community-based programming. And it was written, so long, over 50 years ago, and we're not quite there. However, the Older Americans Act can fund all of the programs for individuals to remain in their homes and communities. And they fund things like adult day health and adult day services, dementia support groups, case management, home delivered and congregate meals, family caregiver support programs, some homemaker, independent living assistance, personal care. They fund senior centers, respite, and most importantly, maybe in the beginning of dementia, is they fund information referral and options counseling for individuals with disability or dementia as well as their caregivers. As I shared with you, the Older Americans Act financing is set up that everybody over the age of 60 is eligible, but they've also put in some strange things so that it makes it difficult for states and localities to increase the funding that they have available because, as I said, it's very limited what we have. So, for example, for congregate and home delivered meals, we can ask for a donation for that meal to be delivered, but we are not allowed to require somebody to pay for that meal. So if you're Bill Gates and you want a meal delivered and you meet the target, you'll get the meal and you don't have to pay anything for it. That makes it harder for us to serve middle-income individuals that would probably gladly pay the $5 or $8 or whatever that it costs to deliver the meal. Similarly, and in a good way, I think, information and referral is totally free, and we can never ask for a cost share for that. This shows, though, what the problem is underlying that mechanism of funding. And this is that the red bar, because I know you can't see anything from the way back, because I was sitting in the way back before, but the red bar shows how many people in the United States are currently eligible for Older Americans Act services. And again, that's a ridiculous number because it's everybody over 60. But what's not ridiculous is to look at that low skinny blue line, which is less than 6% of all of the people that are eligible, are the ones that are actually receiving services in the United States. We're not even able to get up to 200% of poverty in those that are eligible receiving services. So now shifting off of the Older Americans Act and moving into the Medicaid program, the survey that we did earlier talked for the membership about what are you seeing in terms of specific populations, in terms of expenditure growth, and then in terms of caseload growth. Well, what we saw was a very huge increase in the expenditure growth in terms of the Alzheimer's disease and related dementia and the care for those individuals. In addition, you'll see that I think it's 35 states either had increased growth or at least the same growth as the year before for their older adult population, which is very significant. What's interesting, though, is when you look at the caseload changes for Alzheimer's disease and related dementia, the caseloads didn't grow as much. It's just the cost of their care is higher. It's still growing, don't get me wrong, it's still growing in more than half of the states, but it's not growing at 30, not 38 states are saying that they're having more expenses. So one of the ways that the states are working really hard, whether it's being paid for through the Medicaid program or through older adults, funding for the Older Americans Act, is in the adult day programs. And again, I said there's two different mechanisms. There's adult day health, and then there's adult day programming. When we surveyed our states about the home and community-based services regulation, because a lot of these adult day programs are likely not to make it through the HCBS settings without enhanced review, we wanted to know exactly what was happening in those adult day programs, because I think that there was a perception that they're more like a senior center and you go and you play bingo there. But what we found, in fact, was the number of therapies and medical and services that they're receiving to assist them with their activities of daily living was astounding. They're getting bathed, they're getting medication management, diabetes treatment, they're getting transportation, they're getting their vital signs checked. All of these can help to deter avoidable hospitalizations, and so we really want to make sure that individuals, that we can maintain these adult day programs because they're very important. This is another thing that we're concerned about, is similar to the programs for adult day being potentially at risk of being closed. We also are fearful that some of the assisted living models that are out there will also face heightened scrutiny because of their specialty care for dementia, and we want to make sure that they're maintained, not decreasing. And you can see that assisted living and then secure memory care facilities are the two that are most threatened. I'm going to kind of punt this up to Lynn's next thing, because we have focused on caregiving as kind of it's not a federal funding, but unpaid family caregivers are really what is helping to support the state financing and the federal financing of dementia care. And clearly what we have found is that the uncompensated family care that is being given in the United States is $470 billion, which is more than the Medicaid program in total is. It's more than what the revenue of Walmart is, so it's significant. And then we'd like to do these things in infographics. So we have a whole infographic on family caregiving. We have another one on aging. But one of the interesting things is that it equates to about $18 billion of unpaid family caregiving that we're having. And that unpaid family caregiving, I think we need to really focus on, as the doctor said, I think the impact of the disease on the family and the caregiver, their lost productivity, their depression, their insomnia, their inability to sleep because their family members up wandering. So I think that everything, all of the interventions that can be done, I think we need to continue to explore. And I'm very excited that you get to finish this up on the caregiving. Here.
Okay.
Is that good enough?
Yeah, that's good. Okay. Let's see. All right. Didn't come up here, but that's okay. We'll go anyway. So I'm going to go back for 1 minute, and well, we won't go back for 1 minute. So I thank you. I'm very appreciative of being here today, and my remarks are going to build on Martha and Dr. Bustani and really focus on the family partner or friend known as the family caregiver, who has a significant personal relationship with and who provides a broad range of assistance for a person living with Alzheimer's or another dementia. And as Dr. Bustani said, I think for most of us here in the audience, in fact, I'll even ask, how many of you are currently caring for somebody with dementia? Raise your hand. Or have in the past? Or expect to be in the next 5 years? It's all of us, and this is an intensely personal issue that does get bipartisan support at the federal and the state level. But I'm going to focus on the family today because our current service delivery system, especially for long-term services and supports, is based on policies that place enormous burdens on all of us as family members. Family caregivers are generally not recognized as needing help themselves, nor are they supported.
This one.
Okay, that would help. So we can no longer be in denial anymore. Our country is facing an unprecedented care gap in the near future because of the longevity of our population and the aging of the population. There will be greater burdens on fewer family caregivers. This slide is from a paper that I co-authored with 2 colleagues a few years ago, and the major message was, you take care of mom, but who will take care of you? So this means that the caregiver support ratio is declining right at the time when the oldest baby boomers will start turning age 80. And this caregiver support ratio, the proportion of people age 80 and over to the typical family caregiver between the ages of 45 and 64, is going to drop precipitously as the baby boomers age, so that by 2050 there will be less than 3 potential family members for every person who may be at risk for long-term services and supports. So the future looks very unlike the past. So why are supportive services needed for family caregivers of people living with dementia? As we've been talking about, dementia impacts the person as well as the family. This is not a disease or disorders or a chronic condition that just is isolated in the beneficiary in the terms of Medicare and Medicaid. Dementia caregivers also experience more stress than those caring for people with disabilities who don't have dementia. They report more emotional upset, distress, isolation, and financial burdens. They also have more time-consuming roles, typically spending more hours and years in the caregiving role, and rates of depression are twice as high. And dementia is one of the costliest health conditions in our country. The financial risks for dementia caregivers are especially high. Last year at AARP, we did a study that looked at the out-of-pocket costs of family caregivers and found that dementia caregivers reported nearly twice the average out-of-pocket costs in 2016. Nearly $11,000 compared to less than $6,000 for a family member caring for somebody without dementia. And high caregiver stress, be it physical, emotional, or financial strain, are major predictors of a person's placement in a nursing home. There was also a recent study that was published in the Journal of the American Geriatric Society that found that the total lifetime cost of care for a person with dementia is about $322,000 a year. And as Martha was saying, how many people can afford to save those monies for their long-term services and supports in old age? And this research study also documented that of that enormous cost, 70% of the cost was consumed by the family. Medicare and Medicaid paid the other 30%. So families, therefore, should be recognized as individuals who may be vulnerable themselves and need education and skills training and supportive services such as respite care to keep them from burning out. We also need to change the culture of practice and payment from viewing families as just resources for the older adult or the beneficiary to viewing families as a client population who may have care needs themselves. In the Caregiving in the U.S. 2015 survey that the National Alliance for Caregiving and the AARP Public Policy Institute conducted, we found that less than half of dementia caregivers said a doctor, nurse, or social worker had ever asked them what was needed to care for their relative or close friend. This, of course, would not happen in Indiana or Southern California, however. And very sadly and really disturbingly, only about 1 in 4, 24%, said that a health provider had ever asked them what they needed to care for themselves. Caregiver support services are essential for quality of care and quality of life. So this slide shows the range of types of community-based caregiver support services. First, assessing needs, values, and preferences. This means talking directly to the family member, and in some cases, it may be multiple family members involved in the care of someone with dementia. We call this in our field caregiver assessment. Then we have care coordination or care management, arranging services based on an assessment of both the person's functioning as well as the family caregiver's needs, and coordinated with healthcare providers too. Counseling and support groups and family meetings are essential services. I used to work at the Family Caregiver Alliance in San Francisco for many years. One of the most important services that we provided were family meetings where siblings would fly in from all over the country with the person with Alzheimer's disease and the spouse, the primary caregiver, facilitated by a licensed clinical social worker, to talk about care needs and challenges and help with decision-making. These were hugely important services. Legal and financial consultations with knowledgeable elder care attorneys are very important for advanced care planning. And of course, we are so pleased that Medicare now reimburses for advanced care planning conversations. This is critically important. I'm not going to go down this whole slide in the interest of time, except to point out the importance of respite care, either in the home or in adult day programs, as Martha talked about, critically important services. We also need to think about employee assistance programs, because in today's modern world, more than half of family caregivers of adults are also in the labor force, working at jobs like we are sitting around here, and also caring for a family member or friend. And then hospice and palliative care are also critically important services. Now, any dementia model that might be developed by CMMI should, in my view, include these 10 common attributes that are part of evidence-based caregiver support programs. There have been a number of randomized clinical trials over the past 20 years that have proven effective, that really do make a difference in the everyday life of family caregivers. First being the first attribute, adopting the principle of person and family-centered care. You'll notice I'm a social worker. I didn't use the word patient, forgive me. But it's getting to the notion of looking at that whole person, including their family system, and the interdependence of frail older adults and their family members. Second, targeting family members and friends most likely to benefit from the program. It's important to recognize that not all families need help. Some manage on their own, but many do not. And it's that targeting and identifying which family members can benefit from which services that can really improve quality of care and quality of life. Of course, building a trusting relationship with the person in the family is central to good care. And ensuring appropriate language access and cultural competency when working with multicultural families because of the diversity in our country. And assessing the family caregiver's unique needs, problems, strengths, and resources as identified by the family member. This is an opportunity. This is what we mean by caregiver assessment, actually talking with the family member, although in most of our public programs now, practitioners are not reimbursed for having those conversations with family. Asking the family member, how are you doing? What is your greatest worry? What matters most to you? Asking questions of the family member and listening to family needs and worries are fundamental principles of good care planning, especially when the plan of care depends upon the family caregiver. Because as practitioners, we spend a little bit of time with the person with dementia and the family caregiver. But that family caregiver spends the majority of his or her time at home with their loved one. And then other attributes would be providing the family caregiver with a combination of services to address multiple areas of unmet need. We know from research that multi-component service interventions show the most positive outcomes. Tailoring services to the family caregiver's specific concerns and needs is important. Utilizing trained staff. This means ensuring that practitioners and clinicians understand the principle of person and family-centered care and working with family systems. It's also important to offer periodic follow-up or booster support because needs change over time given the functional decline and progressive nature of dementia, and evaluating caregiver outcomes to continuously improve the program. So in closing, just about a year ago, the National Academies of Sciences, Engineering, and Medicine, what used to be the Institute of Medicine, or the IOM, issued an important report, Families Caring for an Aging America. I had the privilege of serving on that consensus committee, and one of the main actions of that report was to call for making family caregiving a national priority in this country. We have a long way to go, but I think with meetings like this and discussions that policymakers are having because of their personal involvement in caring for somebody they love with Alzheimer's or another dementia, we will be making incremental steps moving forward. So the National Academy's report had a number of recommendations, but the one that I want to bring to your attention now is that evidence-based dementia caregiver interventions should be scaled up and made available, accessible, and affordable to the families who need them, because we simply cannot afford to wait. Thank you.
Thanks so much to all three of you, especially Martha, for your great portrait of long-term care in America and some of the challenges that we face in the Medicare and Medicaid programs. And Lynn, nice closing on the caregiver piece, which all three of you have really brought to the forefront today, and which, of course, is very important for people with dementia. So with that, I'd like to open it up for questions, both from the audience to our panelists, and also today, part of the reason we brought you here was to hear what you think, too. So I'd like to invite the audience not only to ask the panel questions, but to come and tell us what you think is the most important thing that we need to know about building a dementia model For example, I mean, Lynn did a great job outlining some services and supports for caregivers, other pieces of what a dementia model might look like as we try to build it. So feel free to come to the mics and, you know, ask questions or make a comment. Tell us what you think.
Hi,
Yes.
my name's Henry Monka. I work at Posit Science. We build evidence-based cognitive training programs that derive from NIH-funded research at a number of universities. And I want to thank the panel for their comments today. The news around what we can really actively do right now to reduce costs and improve care for people who have dementia is really exciting and eye-opening. But I wanted to ask a question kind of one step further back. As Dr. Klein pointed out this morning, we always have to think about how we can spend money on treatment, but also how we might spend money on prevention, because probably the best way to lower dementia costs going into the future, as this tidal wave comes our way, is to reduce the incidence of dementia in any way we can. And as people on the panel I'm sure know, there's more and more exciting evidence coming out. For example, the Mediterranean diet can preserve cognitive function and perhaps reduce the incidence of dementia. More and more studies showing that physical activity can improve cognitive function and reduce dementia. Nicer and nicer evidence coming out around cognitive training and its role in preserving cognitive function. And the National Academy released a report earlier this year suggesting that cognitive training and physical exercise and blood pressure control might all be used to help address cognitive decline and dementia. So as people start to think about what we might think of as dementia risk reduction programs, very much like people have built out diabetes risk reduction programs, I wonder what lessons people have seen on the panel as they've started to think about payment models to support coordination of treatment care for dementia. What advice or learnings people on the panel might have for how we might start to think about payment models to support the reduction of the risk of dementia with some of these kinds of evidence-based knowledge that's coming out. Thank you.
Thank you so much for your questions. Right on target. It's not a question this or that. I think it's both. Early on in 1999, when I made a decision to become a geriatrician, I listened to my wife and trying to figure out if there would be a business for me, in 30, 40 years from now. And specifically, I focus on dementia. So we did some type of forecasting. It looked like in 2006, if you discover that prevention, there will still be 6 million people with Alzheimer's disease in 2050. Yep. So I felt really good from a business perspective. I felt bad from a personal perspective. So I think it's a both.
Absolutely.
As you know, the evidence for the collaborative care model that is as a delivery platform for dementia where you can use caregiver-based intervention, its presence, at least on health outcome, quality of care, and even maybe for cost. The evidence for prevention of that bundle that you're talking about, which I'm very familiar, the efficacy, it's still going, as you know. For sure, there's no harms from it. So we in our center, Standardized Center for Brain Care Innovation, we provide that bundle to the family member who are at risk, but we disclose to them the efficacy. How you gonna create a distribution channel for that one where prevention is the future and make the ROI? Wow, that's gonna be really hard, but we should work on it. And we should try to figure out this ROI for the patients, their family, and even for the organization that will do it. So I'm on board with you that we need to do both parallel effort to take care of the present and also the future.
Thanks, Moaz. Sir?
Hey, my question's on the quality measurement side of the, I guess, same question of prevention of dementia. It occurs to me, in the kids space, we have healthy development as sort of the prevention construct, like ages and stages questionnaire, social emotional addition, tracks your developmental progress as you age. And then you hit age 11, you just go to like depressed or not for the rest of your natural life until you hit dementia. So I was wondering if there was a sort of construct that could be advancing like development into older age using a similar kind of idea that has predictive validity for dementia, but also, I guess, a positive aspect of hopefulness and development.
Wow. I can tell you from geriatrics perspective, here's the big problem trying to create a standardization. The minute you cross 65, for sure when you cross 80, there is no normally distributed variation. The bell curve doesn't work anymore, so it's really flat. So we think whatever the trajectory of whatever you call it, the development, it's going to be very, very personalized. I don't know any kind of effort that I'm aware of to take on your suggestion. I think it's really awesome to learn from pediatrics, and I'm surrounding myself a lot of pediatric colleagues and scientists to learn from them because there's a lot of lesson learned.
Thank you.
Hi, everyone. My name is Efia Owusu-Fofie. Efia just means I was born on Friday, so this is really happening on my day. I am a federal risk analytics consultant with Deloitte and Touche, and that's my regular job. But on the side, I'm leading a nonprofit organization whose mission is to raise up bridge builders that will provide needed programming skills to people in the U.S. and around the world that are in very underreached regions. My question has to do with the deadline. I believe if you go to a hospital and you get bills and you submit those bills, you're supposed to do that in a window. And if you don't, then sometimes maybe health insurance will have a problem, like a 90-day rule. And I just wanted to add that to the conversation, especially when it comes to dementia patients, that these are chronic diseases, and sometimes being in that setting is already stressful enough. And so let's say you were there for 6 months and then you came out, you probably would need maybe 3 or 4 weeks to adjust, to reorient yourself back into your, and then having to ask that patient to submit it within a deadline that I believe is short. So maybe we should think about how we make that deadline longer for people like that. That's, or if you had any comments to add to that.
I'm going to take that one on. I was my husband's caregiver and who had Alzheimer's. And I can't tell you how frustrating it was when you're coming right off the crisis to then get, and we had multiple insurances, trying to figure out what's going on. Some of the Medicare bills and the explanation of benefits. I'm in this industry, and I would be calling a friend saying, I don't know what is going on. Mm-hmm. The whole observation system where the observation stays, where you're actually billed at a higher rate out of pocket, are very confusing for people, and it happens a lot with great frequency because Brian was getting admitted for, or not, he was being observed for things like a bladder infection, which is an overnight thing, right? But then you get home with a pile this high. I think it is part of the caregiver solution, and the legal and elder law people that can help you to process some of the bills in a timely fashion, but I think giving an extension on some of those things I think would be very helpful.
Thank you.
I just want to give a shout out to Deloitte since you work there, because Deloitte this year enacted one of the most progressive paid family leave policies in the country, I believe giving 16 weeks of paid family leave, wow. Not just for new moms or new dads, but also if you're caring for an ill family member or friend.
Thank you. In the back.
Hi, my name is Megan Fidel, and I'm with the New York State Department of Health. Thank you so much for your comments and suggestions today. I really appreciate it. I wanted to share, mine is more of an added comment than a question, but I just wanted to share that in 2015, the New York State Department of Health increased their funding for Alzheimer's disease from $2 million to $25 million and implemented a program that looks very much like what Dr. Bustani described. It's a systems-based approach, evidence-based, and we're really excited to see where it's headed. I just wanted to say, Dr. Bostani, thank you so much for your framework of what it would look like with a reimbursement model. I think sustainability is something we talk about a lot in the program, and thinking about what that would mean for funding for these services is just pretty incredible. So thank you.
Hi, Ashley Delash. I'm speaking on behalf of the American Occupational Therapy Association. And just to emphasize, I guess, a lot of things that the panel has spoken about, but what we've identified as a lot of notable challenges with regard to providing.
Can you speak up? We can't.
Oh, sorry. Can you hear me now? Better?
Yeah.
With regard to providing and paying for coordinated dementia care and caregiver support programs that involve our services, OT services. Some that come to mind for us are initially and periodically administering functional status and cognitive assessments, assessing other factors which impact function and safety, including caregiver support and environmental home modifications needed to enhance safety, therapeutic interventions for those with chronic and progressive dementias, including adapting the environment and activities of daily living to the appropriate level of challenge to optimize successful engagement, identifying behavior triggers, and development of person-centered, dementia state-appropriate non-pharmacological interventions, training caregivers on how to communicate with, engage, and support the patient in a manner that's consistent with the patient's specific health, functional status, and behavioral health needs. We would recommend CMMI continue supporting and gathering outcomes data into existing innovative programs where dementia care teams include OTs who work directly with patients and their caregivers together on key aspects of improving or maintaining functional, cognitive, and psychosocial status to best support them in achieving their daily activities and engaging in social and community participation. One example that we think of comes out of the Johns Hopkins School of Nursing, is entitled New Ways for Better Days, Tailoring Activities for Persons with Dementia and Caregivers, or TAP. TAP is delivered or supervised by an OT and aims at reserving capabilities, physical functioning, and previous current interests of persons with dementia. Thank you.
Thank you.
My name is Jade Gong. I'm a consultant to aging organizations. I wanted to explore a little bit about the employer solutions to the caregiving situation. And I wondered in particular if you saw employers or EAPs as a distribution channel for models like the collaborative care models that were talked about today.
I think what you're suggesting, I think we can use it as a creating market demands. For example, if everybody like Deloitte offer to cover, leave and actually even provide support for the caregiver-based psychosocial intervention, that will be helpful. I'm aware of some health insurance, private health insurance, who are thinking about creating a benefit for the caregiver as a way to, keep your beneficiary involved in that process. So I think it could be a really good market demand. From a distribution perspective, this psychosocial intervention that targeting caregiver, which is primarily, that's what we do in Sandra Eskenazi Center for Brain Care Innovation, require a very scalable workforce. And for me, I think the closest distribution channel that already exists is the area on aging. They have this, we work with them. So we hired at least 50% of our community health workers. It was contract with our area on aging. So I think the area on aging might be the right distribution channels. There's other CBOs like adult daycare could also become at least a part of that distribution channels to deliver the collaborative care model. However, whatever you have to decide to do, the integration is the key with the medical and the social services. And this is why my suggestion is to be more away from process-based reimbursement and focus on outcomes. So you give us like an almost Medicare Advantage for people with dementia, You hold them accountable for certain quality of care, like how many patients with caregivers stress level came over and then within 6 to 12 months their stress level went away, or remission, like depression. How many of them are coming over to the hospital for UTI and staying there 2 days as a bad outcome? How many of them have delirium? And you can hold them for that accountability, but give them enough flexibility to reach out to the community-based organization to create a bundle of an integrated social services and medical service. That's how I think we should try to at least aim for it. than anything else. So that's kind of a long answer to your question, but I wonder if Martha, from your experience, how can you use the employer as a distribution channel?
Well, I absolutely agree with you. I think that from the employer perspective, the importance of offering, again, we don't have a national paid family leave program in this country, although to my dying day, well, I'm working on this, but states are leading the way in this regard. Washington State just enacted a paid family leave program, and the District of Columbia will be implementing one shortly, as well as New York soon. And private companies like Deloitte are stepping up to the plate. Flexibility for the worker who may have caregiving responsibilities is really important, and to make sure that there's paid sick days where you can take time off if your family member has to go to the doctor. Those are important. But for the service interventions, I also think it's contracting with an area agency on aging or a community-based organization that has that expertise. The other reason for doing that from the employer's point of view and the employee's point of view is that still we do face caregiver employment discrimination in this country, particularly when you ask your employer, can I take a few hours off to take my grandfather to the doctor? It's not nearly as uplifting as when you ask, can I please go to my son's soccer game at 3 o'clock? And many workers still want to be a little anonymous in the workplace. So contracting with a community-based organization, I think, is probably the better way to go.
Excellent.
Hi, I'm Dr. Victoria Pham. I work for Change Healthcare, which is the largest IT health technology company. And more proximally, I also am a psychiatrist working with Intercol, which is evidence-based level of care program. My question is, in managing patient with Alzheimer or dementia, is a chronic and very often deteriorating condition. How do you sort of measure the quality of care or the value-based, proposition of the care? Simply because oftentimes the patient may not progress in a certain way, or that is more of a sustaining the current condition. So if you could help me understand some of the measures that is more value-based.
Sure. So that question was on our mind since 2009. So I'll tell you what we have done in Indiana University. So we developed a tool called Healthy Aging Brain Care Monitor. There's a self-report version of it and caregiver report version. It's literally taking what PHQ-9 has done and kind of modify it to expand it to cognitive, functional, on top behavior and psychological symptom. So what we end up looking around, we trying to figure out what measure will get better over time. So the best way you get better over time, it's actually the problem perceived by the caregiver. All right? So I tell my caregivers when they come over, I tell them the following. I tell them, I don't have anything that will make the cognitive disability tomorrow will be better. I don't have anything that will make the functional disability to go better. I have a lot of things to make the behavior and psychological symptom get better, but I also can have something for your reaction to the problem. The problem is require two pieces. You need to have a disability, but also your reaction to that disability can define it as a problem or not. So this Healthy Aging Brain Care Monitor measure the problem defined from the caregiver perspective. And that's the one, when we create a total score, that's the one we see in 6 to 12 months. We end up bringing over family who come over with very high level of perceived problem for that disability. 6, 12 months later, they drop down, there's no problem anymore, despite their loved one still repeating the same story over and over. They now have developed coping mechanism through our psychosocial intervention to kind of not overreact to the repeating problem and everything else. So we have done a lot of these things. I can more help you, share. I'm more than happy to share that knowledge with you. But that measurement-based care is so crucial. Without it, you will end up losing fidelity in processes. So that's one of our more health outcome-based measurement that is relatively less vulnerable for gaming, if you think about it that way.
We have a tool too at Nashua that we, not on the individual, where we're tracking the individual, but for systems and the state systems, quality of care, which is called the National Core Indicators for Aging and Disabilities. 20 states are utilizing the tool now, and what it does is it aggregates surveys on both the health and the social determinants of health aspects. Can you go out during the day? What's your quality of life, et cetera, et cetera. And then you can break it down by the diagnosis. And so if the population in Texas with people that have dementia is less, and they're less satisfied with their lives than people in Florida, why? What's Florida doing that Texas could do? And in many instances, the states have also done it so that they can compare health plan to health plan, if they're in managed long-term services and supports, and they can also compare area agencies on aging to each other in different regions of the country. They can do it by race, gender, all of those things. So it's another measure to see if we're actually improving what we're doing.
Okay, I think we're going to take one more question in the back, and then we are actually going to take a 10-minute break after that. Yes.
Debbie Cagle with Centerstone. I'm curious as to your thoughts around data as we talk about integrated models. And we know that healthcare clinician or clinicians who can share data across the spectrum of services can make better decisions. As we think about our history, meaningful use came to play a few years ago. There was an infusion of dollars for physical health infrastructure in the IT space, but we didn't get that in behavioral health. So thinking about the need for infrastructure build so we can receive data and to advance care through data, I was curious about your thinking and what you're doing today to advance that.
Well, I would just thank you for that. That's very important, and that goes back to actually identifying the family member who may be providing care to that older adult with dementia or another person with a chronic condition. So there are, as of today, 39 states that have enacted the CARE Act, and this is an act that came about through advocacy of AARP state offices as well as collaborations with state agencies on aging and community-based agencies for when someone is admitted to the hospital, for that person to have the right to state whether or not they'd like to have their family member noted in the medical record, which requires an IT resolution. That's the first step. The second is to then make sure that the family member is notified prior to discharge from the hospital, because they will be asked to take on medical nursing tasks at home and then to train them on those tasks. But the first piece is actually changing some of the practices in hospitals to have the record identify the family caregiver. So that's just one area that's just starting to emerge across the country.
Very good.
For us, we really have leveraged the patient-reported outcome that most electronic health records have a platform there to do it, and we just used it to include the HABC monitor like PHQ-9 and GAD. So that's one piece. The second one, since 2017 early on, one of the G0505 that CMS mandate, I'm not mandate, but at least I don't know if it's mandate or require, but require a brain care plan to develop where you have to specify the caregiver, and then we take that, put it in Epic, then you have a tag between these, both of them, that will do this. We're using both of these issues, the caregiver and the PRO, to actually improve our predictive analytic to figure out who's going to be rehospitalized 30 days. As you know, electronic health record base are really not that much better than luck. So if you add to it the psychosocial element, we've been able to create an ROC that 0.9. So it's very, very good prediction. That's how we've been able to leverage the data The other piece we try to figure out is when you go to population health pieces, then the medical record contribute very small, even if you have health information exchange. So we are now working with our community-based organization, social services, to actually bring them over to our health information exchange and create, and take their social determinant of health and behavior determinant of health in a way to create a much better snapshot of the health of our population. So that will be a really awesome way of integrating more data outside of the medical record.
Thank you.
This panel has done a great job of raising the profile of caregiving and the importance of caregiving in terms of not just behavioral health, but specific to people with dementia. At CMS, we know that many of these caregivers, in addition to the person with dementia, are also beneficiaries. So we have a dual interest in serving them. So if you could put the website or the mailbox back up, that would be great. In case anyone didn't get their comment in, there's the email box again. Please feel free to send us your comments about how to develop a dementia model. And thanks to our panel, we're going to take a 10-minute break, and then we're back for our last and fourth panel. Thank you.
just wanted to huddle up and address the whole IT topic.
Hello? I think we're going to go ahead and get started. I know people have planes, trains, and automobiles to catch, but we wanted to end the day with a topic that is personally near and dear to my heart, which has to do with the workforce in the behavioral health arena. We've certainly heard a lot of that in different places as we've gone through the day, and it's our last panel. So I want to go ahead and introduce Dr. Vatisha McClare. She's one of our senior social science researchers in the Innovation Center, and she's going to lead us through this next panel.
Thanks, Chris, for that introduction. Before we get started, I want to thank the audience for being here at 3:30 on a Friday. I know it's hard. I was pretty afraid there were going to be 5 people in the audience, so I am very happy to be proved wrong. We have hopefully what will be a very entertaining and engaging and interesting panel. We have some experts in improving the behavioral health care workforce. Okay? So I want to introduce our speakers. Before I get started, I want to say that one of our speakers, Mary Zelazny, was not able to attend today, so we will have 3 panelists. First up, we'll have Dr. Lori Rainey, who is the co-chair of the American Psychiatric Association Council on Healthcare Systems and Financing. Then we have Daryl Donlin, who will give us our payer perspective. He is the Vice President of Network Operations for New Directions Behavioral Health in New York. And lastly, we have our federal perspective with Andrea Harris, who is a lead public health advisor at Substance Abuse and Mental Health Services, SAMHSA, Center for Substance Abuse Treatment. And she will provide information on federal programs that address these very complex behavioral health workforce issues. So we can get started with Dr. Rainey.
Great. Thank you. I'm very happy to be here today. I see that the crowd's down to about 1/3 of where we started this morning. But if you're not here because you're worried about the behavioral health workforce, I don't know what's up. How many people here have trouble finding someone to work? How many people have trouble finding a psychiatrist? Yeah, so I mean, it's the whole crowd, right? So we should have started here, right? Okay. It's a huge issue. It's a national issue, but it's not important enough on a Friday afternoon to keep the entire crowd here. But that's okay. We'll deal with that. I want to mention that you're going to see some yellow stars. I don't want to be a whiner. I actually want to give some solutions, talk about solutions. So every time you see a yellow star, I hope that that's a possible solution to what's happening with the workforce shortage. Let me do a little whining first and tell you what I think a lot of you probably already know. Why are there issues? Why are there problems? Why are there gaps in care for people with mental illness and substance use? And if you've ever actually, how many people here are behavioral health providers? You've actually built a CPT code, an E&M code, right? It's a little tough. We've historically faced all kinds of limits in insurance coverage, co-pays, all kinds of things. So it's been an issue for mental health for a very long time. There hasn't been parity. A lot of you may know the Tara Bishop study, where 77% of the counties in the U.S. have no behavioral health person. Not only not a psychiatrist, but no behavioral health person. A lot of psychiatrists don't accept insurance of any kind. They're doing cash and carry practices, and the reason they're doing that is psychiatry got hit the hardest by managed care and what happened back in the 80s and 90s. And so a lot of psychiatrists just opted out. It wasn't worth the energy. If you're in a cognitive specialty, if you're not doing procedures, you're certainly going to make a lot less money and have trouble putting your kids through college and paying your mortgage. That's been that's my life. And then parity requirements. We heard this from Patrick Kennedy this morning. No holds barred. We got some problems even in our own federal programs with lack of parity for Medicaid and Medicare. So all kinds of issues facing behavioral health and playing into the behavioral health workforce shortage. One of the questions that I was asked to specifically address today is, why don't psychiatrists take Medicaid? That's probably a straightforward answer. I think we've already heard the answer to that multiple times. But what I wanted to show you was a slide about all physicians. So it's not just psychiatrists. Across the board, a lot of physicians, a lot of practices don't take Medicaid. And some of the reasons are very simple. Most people said it's reimbursement. You get $42 for trying to take care of a complex patient with a mental health condition, but it's not just that. There are a lot of things going on. Also want to point out, dermatology's right in there with us. No one's, I think, asking the dermatologists why they don't take Medicaid, but if you notice the lines here, we certainly have some folks right in our camp in terms of not taking Medicaid. I will say the huge exceptions to this are FQHCs, Fairly Qualified Health Centers. They will trip over themselves to get your Medicaid. Why? Because they have a PPS. They have an extra payment. That's what we're talking about here, is getting extra payment to do the work, or getting adequate payment to do the work. The other thing is in community mental health centers. If you've got Medicaid, if you have SMI diagnosis, a lot of folks have access to care. That's where we all are. I'm a community psychiatrist. I hang out in community mental health centers, and all of our patients are Medicaid. Bring them on down. That's the group we want, especially the SMI population. What are the other reasons besides payment that folks don't take Medicaid? It's because it's administratively complicated. Anyone here ever tried to bill Medicaid for a patient? It's tough. You bill and you get it back and you bill again and you bill it, and you just go back and forth, and there's a big delay in the time that you see the patient and the time that you get paid. I mean months, 3-6 months. It's a big delay, and if you're trying to manage a practice and finances and pay everybody, if there's delay in reimbursement, if it's administratively complicated, a lot of physicians will actually opt out. The patients that are on Medicaid often are a little bit more complicated. They're sometimes lower socioeconomic status. They've got multiple chronic conditions. They're complex patient needs. And this is the other problem. You got a patient with a heart condition. You want to refer them to the dermatologist. Guess what? Dermatologist doesn't take Medicaid. So you're trying to take care of Medicaid patients, and people don't want your referrals. So all kinds of things we need to think about, simplifying this administrative process, speeding up reimbursement. And those are the things CMS can do, and reducing that administrative burden of trying to take care of Medicaid patients. Notice the star. I told you solutions. I want to work on solutions today. So when we think about alternative payment mechanisms and sort of what that should look like, we need, for behavioral health, we kind of have, the American Psychiatric Association's worked a little bit on this sort of idea of these core principles. We want it to meet the triple aim. You want to have these payment mechanisms help improve care, reduce costs, increase access, and we hope that patients actually have a better experience of care. We need to have these APMs designed specifically for people with mental illness, not to just sort of, not randomly, but globally apply a strategy that we use for other forms of health care or surgery. We want it to really feel like it's mental health. You really need input from mental health people, psychiatrists, psychologists, social workers, therapists. Let us all kind of help you out here. Participation, does it need to be mandatory? Can it be voluntary? Are we going to force APMs on people? Just something to think about. A lot of behavioral health systems don't have EHRs, don't have good EHRs, and we were actually left completely out of meaningful use, if you guys remember that. I think we came back and solved that problem later, but behavioral health was treated differently just in meaningful use incentives. And we really need to figure out within the field how to support the delivery of services by telehealth, which we're going to talk about at the end. Here is the Bishop study. Again, this is looking at these are the distribution of psychiatrists across the country. This came out in Health Affairs last year. And guess what? Psychiatrists like coffee shops, theaters, shopping, just like everybody in this room. How many folks here live in the area? Yeah, a lot of you. You like the big cities, right? It's comfortable. It's nice. There's all kinds of fun things to do. Well, psychiatrists like that too. So they don't go out to Wyoming, North Dakota, South Dakota. They don't go out to the hinterlands and practice medicine. So what's the solution to that? Well, telepsychiatry is an incredible solution. I want to say to people, don't think of telepsychiatry as a workforce shortage solution. It doesn't make more psychiatrists. It deals with the geographical maldistribution. So my hope is all those people hanging out in San Francisco, San Diego, Washington, Seattle, you can see the towns, right? That they'll be willing to beam out west where I live in the middle of nowhere and actually provide services via So that's a geographical maldistribution solution. You see the star. The biggest problem is the daggone barriers to telehealth, and you heard that today. Everything from payment to Medicare's, you got to be in a shortage area to do this. The originating site, can you do this at home? Every state's different. If I'm going to beam into Florida, I've got to have a Florida license. It takes 3 to 6 months to get a Florida license. These are the complications that we have trying to provide telepsychiatry, teletherapy, and one of the things, if CMS goes again, they're looking for some input, is to remove these daggone barriers to doing telehealth. Now, all day long, everyone has stolen my thunder. I am an expert in the integration of primary care and behavioral health. I'm a master trainer in the collaborative care model with the APA, and all day long, Patrick Kennedy, Henry Harbin, Verna Little, the whole crowd stole my thunder. They talked about the collaborative care model, but I'm going to give you the details because they talked about this thing that's out there, and I want you guys to actually know what it is, because for me as a psychiatrist, telepsychiatry and the collaborative care model are an answer. They are answers to the shortage of psychiatrists. Our joke is trying to find a psychiatrist is like trying to find a unicorn, right? There aren't many of us, and then try to find a child psychiatrist. 4-6 month wait for child psychiatry. It's incredible. So the goal of this model is to improve care and to use psychiatrists completely differently. Okay, so let's go through the model. In the model, what we have is one of these things going to turn this off or let me point? Anybody know? I might turn it off. Whoops. Let's not do that. Okay. To the right, what we have is in the primary care clinic, we have help. And could be a social worker, psychologist, it could be a paraprofessional, it could be a licensed therapist, whatever it is. At the elbow of the PCP, we have help. Okay? Totally behind the scenes, we have measurement-based care. We have repeat measurement tools. You've heard about this all day long. We have tools that we can apply. We measure, 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 and if the person isn't getting better, we do something about it. We change the meds, we change the diagnosis, we get some labs, we refer them to another form of treatment. But we measure, 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 and we don't stop. We're relentless about measurement-based care. I'm going to skip over to the registry. The way that you do population health means I'm going to write your name down and I'm going to be accountable for you. I used to work in the 90s with the Navajo Area Indian Health Service, and our registry was a file box. And the diabetes nurses would flip through the file cards every day and see who needed what. That was our registry. So I got used to the registry way back in the 90s. So we're going to track the folks that we are providing care for, and we're going to do something about the people that aren't getting better. The other thing we're going to do is we're going to provide psychiatric consultation. Notice the psychiatrist is behind the scenes. When you have a shortage specialty, you do not have them seeing patients with mild to moderate mental illness over and over and over again in their office. That is a waste of my experience. It's a waste of my training. Save me for people with severe and persistent mental illness for face-to-face evaluation, and let me get completely behind the scenes and help primary care do a better job of providing effective care. And there's two ways we do this. One is I am on the phone. I answer the phone. This morning, a primary care provider called me. You guys are going to love this. 24-year-old guy, history of anxiety and depression, trying to get off heroin, just got out of a halfway house, shows up in a primary care clinic this morning. Anxious, PHQ 9 of 21, trying to get off heroin. And I'll say my sister, because it's a PCP and she is my sister, called me with her hair on fire. She had no idea what to do with this patient. And I picked up the phone and I answered it. I am staying at her house tonight. I do live in Colorado, so I picked up the phone, thinking we were doing dinner plans, right? And she had her nurse practitioner students on the phone. She wanted them to listen to what it was like to do a curbside consultation and let them listen to me and her talk. It was fabulous. This guy had called 36 psychiatrists in the Baltimore, Washington area. Guess how many appointments he got? There you go, everybody in the room. This is a big cities, Baltimore and Washington. 0 people answered the phone or gave him an appointment. 0 in your big city, okay? So he shows up in primary care where my sister is completely inadequately, except I'm there for her, trained to do this work. And I answered the phone. That's number one, readily available, answer the phone. Okay, we got trained psychiatrists to answer the phone. They're like, we don't answer the phone. Okay, we got to work on that. The second thing is the registry review. So once a week, I sit down with the social worker, the gal in the red shirt, and we talk about the people who aren't getting better. You probably can't see it in this slide, but there's a bunch of red dots in there. Those are highest PHQ-9, highest GAD-7s, new patients. That's who we talk about, okay? This is what happens to the psychiatric, my expertise. 2 hours a week per care manager, 1 hour to do the registry review, 1 hour to answer the phone. They each have a caseload of about 75. During the course of a week, this is in 1 8-hour day now, 4 care managers, 2 per. I'm taking care of 300 patients in 1 week. That's one of the big solutions to the psychiatrist shortage. We aren't going to make more psychiatrists. Everyone's trying to somehow figure out how we get more than 4 to 5% of medical students to want to go into psychiatry. Believe me, guys, being a psychiatrist, you guys are looking at me and going, oh, she's a psychiatrist? Because it's stigmatized to be in the behavioral health field, period. My dad said to me, well, Lori, why can't you be a real doctor? He wanted me to, I don't know, do OBGYN, but there's a stigma to being a psychiatrist. So anyway, we're not going to get more than 4 to 5% of medical students to choose psychiatry, so you got to use us smarter. You got to use, and the collaborative care model allows you, I think, to take one psychiatrist and increase their ability to cover a population by an order of magnitude. That's 10 times. One psychiatrist, you make them into 10. Okay? And that's to take care of this behind-the-scenes work. Now, what you can't pay for is everything behind the scenes. No one pays you to do curbsides. No one pays you to do training. It's a heavy lift for the primary care practices to get this going. Heavy lift. They have to hire everybody. They got to hire me on a whim that maybe this is actually going to pay off somehow. But they have to do a really heavy lift, and you have to train everybody. So there's a lot of work behind the scenes that goes on, and we've heard that all day today. Care transitions, care management, care coordination, that's what works can't be coded. And that's the kind of stuff that actually works in healthcare. So behind this collaborative care model is all this action going on. And here is me. If I can get a psychiatrist to work 8 hours a week, that's one day, they can take care of 300 patients simultaneously. All right? Sweet deal. Now, psychiatrists don't do this all day long. I'd go crazy if I had a 40-hour week like this. I'd have about 20 social workers and lots of case reviews. It'd be too much. So half the time I might do this, and half the time I'm going to be in the community mental health center taking care of the SMI population. Okay? So it's part of my work, not all of my work. The psychiatrists get a little nervous when you talk about this. They say, oh my God, I'm never going to see a patient. And it's like, yes, you are. You're going to go to the jails. You're going to go to the mental health centers. You're going to go to the hospitals. You absolutely are. And I'm halfway convinced all those psychiatrists that do a cash and carry practice, that maybe I can pull them out. I call it Give a Day. Give a Day to Primary Care. Be our new campaign. Can we pull these cash and carry private practice psychiatrists out of their nice protected practices and actually give some time to primary care, half a day, something. And I think we're going to be able to do that. That's my next pie in the sky. Here are the codes you've heard about all day long. All right? These are the codes, the infamous codes. Thank you so much to CMS. We are so tickled to have these. We have a problem, though. No one's using them yet. We're 9 months in. I just heard of one person that got their first $133 today. Several reasons for that. Number one, these are Medicare codes. Most of us work in Medicaid populations. We have got to get these codes out to Medicaid. We've got to get private payers. For all those private payers that showed up at Patrick Kennedy's house and took all those notes, none of them are covering this model yet. If there's one in the audience, please come to the podium. Not now, at the end, because that's the problem. Patrick Kennedy talked about how excited they were, and now they're all waiting for each other to go first. It makes me nuts. But they're all waiting for each other to go first. And in Medicaid, nothing. First one out of the block is going to be Washington State. They had to pass an appropriation to pay for it when it has a 6 to 1 return on investment. If you treat depression, guess what? Physical health gets better. They had to pass an appropriation in order to do the collaborative care codes. They're the first ones out of the box July 1st. Big star. We got to get this to Medicaid. This is my last slide, and maybe I can make up a little bit for our other speaker who couldn't be here. Remember those hinterlands? Remember, there's no social workers. There's no one in 77% of the counties. So we all want to do this fabulous collaborative care model thing, right? Well, there's nobody out there. There's no one out there to do it. So one of the really big focuses right now is how do we get behavioral health using technology out to the masses? And I put this in 3 buckets, and I'd be real curious if people have other buckets. But the first bucket is, what can we get patients to be doing? Online CBT? Can we send them some affirmations? Can we ping them to do a PHQ-9? What is it that we can do in the patient bucket side to help us do this work? In the middle, I've got building primary care capacity. These poor guys, they just simply didn't learn how to treat behavioral health in their residency. If you ask them, how much time did you get? I asked a group of third-year residents in a family medicine. This little guy in the back held up his fingers, and I said, oh, well, okay, 3 months, that's okay. And he shakes his head and he goes, 3 weeks. Primary care is completely unprepared to do this work. So what are the options? Being able to have decision supports, things that pop up the minute they put in the diagnosis of depression. E-consult is an up-and-coming form of getting consultation from especially psychiatric providers in psychiatry. Project ECHO, some of you may have heard about. It's a really nice telementoring educational program. Primary care providers can get CME credit for it, and for at least 12 to 16 weeks, they can present their cases. And you can do the collaborative care model from afar. You don't have to be in that office. You can actually provide these services. You can have a social worker in a bunker. I'm always just on the phone like I was this morning. I don't have to be anywhere. You can provide all the elements to build the collaborative care codes from afar. And then the last thing you do is telepsychiatry. People run to telepsychiatry first. you might want to think about telepsychiatry close to last. That's what you do if some of this other stuff doesn't come together, or you do it in combination with these other things in that hub potentially. Okay, my time's up. I got the hook.
Thanks so much for that presentation. We're actually going to come back to that kind of technology-enabled behavioral health a little bit later in our Q&A part, because we think we want to spend a little bit more time on that. But next up, we have the payer perspective from Daryl Donlin from New Directions Behavioral Health.
Yes, hi. Good afternoon, everybody, and thank you so much on behalf of New Directions for us to be able to speak to at today's event and talk about some of the exciting things that we're doing to really help promote care, but to do it in a way where we're looking to be creative, to really partner with our providers, and to really do it with the member coming first, and to address it in a way through a different type of payment model where we're able to really look to extend the workforce that is available. So just in terms of introduction, New Directions, we are a behavioral health organization. Right now we have 13 million members, and we work with 7 Blue Cross Blue Shield partnerships. We're just not exclusive to Blue Cross Blue Shield, but right now they're the partners that we're working with, but we are looking to expand out of that footprint. We have over 500 employees, and we also have an EAP book of business, which is 2,000 plus employers strong. So the types of things that I would like to talk about today are really dealing with, I guess, a couple things. So one is to share with you the challenges that we're facing as a payer, also the different types of things that we've done to search for solutions, and then how we ended up really landing on some best practices that I would like to share. Talk about the reimbursement for these non-traditional services that are through a bundled payment model, and to share some of those lessons learned. So, due in large part with the exchange population. So, predominantly New Directions, we have, I would say, mostly a commercial population, but now due to the exchange over the last couple of years, we're seeing a very large influx of those members. And what's happening now is that it's a much different population that we're dealing with more than ever. And it's much more of a Medicaid type of population that we're dealing with in terms of the level of acuity, the types of social determinants of health that members are struggling with, looking to overcome. And the challenges that we're facing, especially now with this type of population, is really things such as higher readmission rates, the rising cost of care, but then also I had mentioned a little bit earlier about the high level of acuity. So these things are extremely important, and it also needs to be addressed in a way that right now our existing model, our network model, so to speak, is just not capable of handling. So our existing model is really comprised of your traditional, I would say, a network of providers consisting of residential treatment centers, inpatient facilities, intensive outpatient, partial, those other higher levels of care, as well as your professional outpatient services. So typically your physician, your therapist that's in their office with typically a 50-minute session. So those things are becoming quite a challenge, especially when you take into account now medical conditions and then just life obstacles that people have. So to the left, we're talking about the challenges. To the right, unfortunately, these are the tools, the traditional tools that we have used in the past to deal with. And those tools are not sufficient anymore. So the 50-minute session, we need to have different things come out of our provider network to be able to assess, to be able to really address the types of challenges that our members are seeing. And also, in terms of us being able to engage members, right now, and this is evolving as we speak, but again, traditionally, it's always been with a therapist in a cubicle with a headset, doing outreach to members with these array of complex conditions. So the status quo, and for us to do the same and expect different results, we all know that can't continue. So I would like to share with you some of those things that that we are looking at, and we developed a wish list of, my gosh, wouldn't it be great if we could have A, B, and C come together through our provider network to address those challenges. So in terms of the wish list is really looking to make care as convenient as possible. I have, and this is again a wish list, to overcome social determinants of health. I think we would all be happy if we could help make an impact on those social determinants of health and really help manage them better. Focusing on strengths and resiliency is so important because many times, again, in the traditional world of behavioral health, it tends to be more of a deficit-based type of clinical profile that our members bring. And so we really want to move away from that. Other things such as closing gaps in care, whether it's medication compliance or, again, making sure that the different types of healthcare services are being taken advantage of, whether they're mammography or something else. But then also to increase not only member engagement, but family engagement. And then we believe by doing all of those things that we will really be able to address and improve outcomes. So we had taken a look at what can we do in terms of this wish list? What's out there? What can we put together? And I'm not sure if your organization is like ours or other ones I've had experience with. Sometimes the most dangerous thing to do is to really plan a solution inside the four walls of your office without really considering the strengths and the abilities that are really out there in the network, in the provider community. So this is what we really did. We really took a look at what's in the provider community and what are the best practices. And as we all have heard, the best practices are in the public sector. It's community mental health centers, in this example, that we, in a sense, are looking to use as a behavioral health home. And with the community mental health centers, what we have found through multiple conversations with them is that they're not working with commercial payers to deliver their bailiwick of services. So that's just not happening. So we saw this as being a key opportunity for us to bring those Medicaid best practices over into the commercial world. So not to say that we developed this concept, but we basically just developed this phrase as a way of looking to name the program, which is behavioral health homes. So it's not a place, it's not a destination, but it's really a concept in terms of how care gets delivered. And the main focus of the behavioral health homes is to specialize in what they're very good at, which are members with these various challenges, but then also to make sure that we are dedicated their time and services to really focusing on those types of members. And so some of the services that they're providing, it's really comes under, I would say, a couple categories. The categories would be they provide mobile services, they provide on-site services, and they're also able to go into the patient's home, which is a beautiful thing. And now in terms of the mobile or on-site services, what we are able to arrange for, and we found this to be very important, is to really start the relationship with the patient while they're still on the inpatient unit. So they are able to provide a quote-unquote on-site meet and greet by being able to establish a relationship with the facility, which we help broker. Through that relationship, through that agreement, the behavioral health home clinicians are able to go onto the unit before that patient gets discharged and to establish a relationship that way. Therapy does not take place, but it's hi, this is my name, I would like to get to know you better, and I would like to work with you once when you get discharged. Are you willing to do that? So that's how the whole process starts. The beauty of this program is in the second bullet. So it's in-home therapy, but most importantly, in-home therapy with targeted case management. This all deals with the wraparound service model that now, again, we're bringing over into the commercial side, and we're able to leverage the skills and abilities that our behavioral health homes are able to bring to bear. Certainly, the plans are individualized and customized for each patient. And it's a matter of coordinating all of those services to overcome those social determinants, to overcome the medical behavioral integration, and then to provide those targeted case management services to make sure that patients don't fall through the cracks upon discharge. Now, the length of the program typically is about 30 to 120 days before that episode of care is closed out. And with the therapists involved in the behavioral health home, it also provides 24-hour-a-day coverage. Again, extremely important when you're taking a look at that small percentage of your membership that's driving about 55 to 60% of your costs. So that becomes extremely important for us. Now, in terms of, this is the practical piece of, I would say, of my discussion today, and so something for me to leave with you, and we'll also talk about how this model gets done in terms of what the codes are. So I'll be more than happy to share that. And this is really the fun part of my job, which is to take a look at the problems that we're all discussing today. How can we partner with our providers to develop a solution? And then based on what we discussed, how can we really look to implement that? And so what we've done is we created a payment bundle to pay for these services. So what needs to happen according to the rules that we need to abide by as a commercial payer is to make sure that there's a licensed clinician. A licensed clinician needs to be, in a sense, at the end of every service that gets delivered. Different rules compared to Medicaid, but these are the rules that we need to abide by. But we wanted to make sure that that really didn't stop us. So what we've done was also wanted to make sure that we included targeted case management, which could be the clinician, him or herself, doing the services, or it could be a non-licensed person that is under the supervision of a licensed clinician to make the connections and to do the outreach to help coordinate care. And so we've done this through a bundle payment. And so the payment is able to, it's flexible enough where it's a one-time a week payment, and then that payment you could really look to flex the payment based on the level of clinical intensity that's required. So I'll talk a little bit more about how this, about what's included in the bundle payment a little bit later on, but it's flexible and you're able to customize it. In a sense, it gets paid once a week. So in terms of payers being concerned about, my gosh, I want to make sure that I'm not paying for a full month of treatment if the patient is only participating 1 or 2 days, this is, in a sense, it's a win-win for both sides to be able to do that. And then the amount of targeted case management hours, we sync that up with the level of clinical intensity. So if there's a small number of clinical hours that are needed, we then expect that the number of targeted case management services would equal that level of clinical interaction and clinical work. So in terms of how all of this plays out, it was interesting as we had really gotten to this stage of coming up with what are the codes, how can it be billed. The most important thing with all of this is as you get together with people within your organization, what happens is that everybody has the best intentions. The best intentions sometimes could be so complicated to be able to implement. And then everybody's, in a sense, collective genius gets in the way of being able to now execute what's really in the best benefit for the member. So what we've done and what we really needed to do and ingrain with everybody is, look, let's keep it simple. This is only as good as the ability for the claim system to pay for this accurately. So I'm not calling this a simple model, I'm calling this a very well-educated, elegant model to be able to get these services paid and not to hold anything up as it relates to reimbursement. What we wanted to find out was, is there a way for us to not recreate the wheel here? So when we're working with our behavioral health homes, what are you doing elsewhere? And we'll just mimic that. As we had found out, we asked, are you working with other payers? They all said yes. As it turned out, they're all working with Medicaid managed care payers. And apparently none of those payers had brought this over to the commercial side. So then it was a change in education with CPT codes, how to bill for that to move away from the HCPCS codes, et cetera. So a good deal of training and education went into this. And then these are the codes that we're using, and the codes are really paid for, the codes are really paid by the level of hours that the clinician uses, and then that syncs up with the amount of activity that care manager needs to do. When we went into this, and this will be my last comment to wrap up, is that, again, first time that the behavioral health homes were moving into this, and so we wanted to make sure that as a partner, that it's one thing to have a need for us to come to them with, I have a problem, can you help me? But it's another thing for a payer to talk about what the demand is. And so some of these terms were used earlier today. So if I could come to a provider and say, I don't have a wish list, I have a demand. My demand is backed up by what I'm willing and able to pay for this. That's a totally different conversation to have. So then that kind of sets the stage for a good deal of safety financially for the mental health center to work with us, and then for us to be able to get this rolled out. So what we've done with the community mental health centers is that through an NDA, we got that signed first, we shared utilization data. So then we could talk about the demand that we have within that pocket, within that geographic territory of where they're providing services, of members that have an SMI type of diagnosis, and for us to best target and estimate the volume of referrals that they could expect. So through this whole process, we're able to develop a behavioral health home bundle payment mechanism, and this has been actually quite successful, and we've been very pleased with the outcomes.
Thank you so much for that. I think it's a really important issue and a really innovative solution for addressing the needs of a population which we haven't talked very much about today, but those who are newly insured through the health exchanges. We know that these people have a lot of unmet need, and we know that they also may have a lot of undiagnosed mental health issues. So I think that was really interesting. Thank you for that. Our last speaker is Andrea Harris from SAMHSA.
Good afternoon, everybody, and thanks for sticking with us. I'm going to talk to you a little bit about some of the efforts at SAMHSA to address the issues and challenges facing our current behavioral health workforce, and I think many of these have been touched on throughout the day, and hopefully I will kind of synthesize them in my discussion. And then I'm going to talk to you a little bit about some of the research that we're doing at SAMHSA around healthcare financing. If I can get the technology to work for me here. All right. So when I first entered the field, when we were talking about, especially in the substance use disorder field, our workforce, we were primarily talking about addictions counseling professionals and 12-step groups. But now I think with the complexity of the substance use disorder treatment needs of our clients, we have broadened our definition of the behavioral health workforce to include PCP providers. I think you all have discussed the integration of substance use and mental health disorder treatment into physical healthcare settings today, and we see the role of PC providers as key in helping us to identify and treat substance use and mental health disorders. We also are broadening our definition of the workforce to include peers as we look at the role of peers and peer-run programs within the context of traditional treatment programs. And then our specialty providers, or those people that primarily deal with the SMI populations. So why do we have a need to grow our current behavioral health workforce? Well, one is that we have, as I said before, a complex issues when we're dealing with substance use disorder clients and their treatment. And as our field has broadened and the need for addictions treatment has increased, we have a lack of providers to address the increases in people needing substance use disorder treatment, especially with the opioid crisis in our country. As Dr. Rainey was talking about, we also have geographical shortage areas, which has led us to the need and looking at other ways to treat people other than traditional one-on-one settings or clinical settings. We also have some recruitment and retention issues. There's not a lot of people that enter this field with the idea that they're going to make money. It's been a grossly underpaid field, and many people are not attracted for that reason. We also have licensing and credentialing issues. I think someone touched on the issue of portability of licensing from state to state, because each state has its own credentialing practices and its own licensing practices, and a person may be licensed or credentialed in one state and not be able to practice in another. So we're working in that area. And also we have an aging workforce. So who licenses and develops the workforce? We already talked about the fact that that is primarily done at the state level, we have clinical training programs and regulatory bodies that are state-run, and again, guilds and other credentialing groups that address the workforce issues state to state. Then we also have our payers and other networks that address who it is that will receive payment for providing clinical services. So with some of the challenges that we have around substance use disorder workforce, what are some of the things that we're doing at SAMHSA to help address those? And one is we have developed a lot of continuing education projects and programs for substance use disorder treatment professionals. We have our Addictions Technology Transfer Centers, which is at the bottom, but I'm going to group it up in there. And they are primarily concerned with service to science and helping to increase the utilization of evidence-based practices among SUD professionals and the behavioral health workforce. We have also been working on and are continuing to work on and develop competencies for the substance use disorder treatment professionals in a way that we can work to try and get better state-to-state equalness in terms of the KSAs around substance use disorder treatment providers. In order to attract different people to the field, SAMHSA has a Minority Fellows grant program, and we have a Historically Black Universities and Colleges grant program. We also have interns from the Historically Black Colleges and Grants program that come to work for SAMHSA, and hopefully this is a way to help give them a chance to see how the behavioral workforce operates. We also provide a lot of technical assistance to states, communities, and behavioral health providers through our grant programs and a variety of different contracts that we have throughout the country. And then again, I'll mention our Addictions Technology Transfer Centers. Some of our efforts around the substance use disorder workforce, as I said before, involve inclusion of identification and referral services into primary care settings. And one of our primary efforts around this is with our screening, brief intervention, and referral, or SBIRT, training programs. We have a variety of different student grant programs as well as programs that reach primary care physicians and other health professionals that can assist us in the identification and referral of clients with substance use disorder treatment. We also have state-targeted response to opioid grants that are aiming to address the opioid crisis by increasing access to treatment, reducing unmet treatment needs, and reducing opioid overdose-related deaths through the provision of prevention, treatment, and recovery activities for opioid use disorder. And these grants were awarded to states and territories via a formula based on unmet need for opioid use disorder treatment and drug poisoning deaths. We also have the utilization of peers and traditional SUD treatment to help address some of the unmet needs in the addictions professionals deficit, and are looking at more peer-led programs as alternatives to traditional SUD treatment. We also, in collaboration with HRSA, which is one of our sister federal agencies, we fund the Behavioral Health Workforce Research Center, and this effort works to strengthen the behavioral health workforce by conducting studies that can improve development and planning efforts. It is engaged in several projects designed to improve data collection, estimate workforce size and composition, and assess the scope of practice for the behavioral health workforce, and it's located in the University of Michigan. We also have our Center for Integrated Health Solutions, and this is a national training and technical assistance center that promotes the development of integrated primary and behavioral health care services and related workforce development issues. The CIHS provides training and technical assistance to behavioral health organizations that have SAMHSA primary and behavioral health care integration grants, as well as to community health centers and other primary care and behavioral health organizations. SAMHSA also has regional administrators that are placed in all the 5 regions across the country, and these folks represent SAMHSA in the national, regional, state, and local communities and connect our stakeholders with promotions that advance behavioral health and engage target populations, help to develop, support, and lead collaborative initiatives across HHS and other federal agencies to assure behavioral health is a priority throughout the nation. Another area that we haven't talked too much about today is the integration of primary prevention into primary care settings as well as into behavioral health care settings. And the prevention workforce is a little bit different than the traditional SUD treatment workforce, and that they're really adapting to new territory and are operating in multiple healthcare settings. They have people with varying backgrounds, skills, and knowledge operating depending on where they are located. So the growing of the substance use disorder prevention workforce is a challenge in that they do operate in such a different way. But they are we see them as an integral piece to the whole behavioral health and primary care setting integrated process. I talked about SBIRT, and I just wanted to give you a little bit more information about that because we see this as a very promising practice as we are developing more integrated models of care. And the SBIRT program is one of our effective and productive workforce development activities. Over the past 15 years, SBIRT state grants have trained countless primary care providers at all levels in the provision of clinical screening, brief intervention, and referral to specialty treatment. In addition, the SBIRT student training grants have trained over 10,000 medical residents, nurses and social workers, and counselors and others in the practice. The result has been over 2.5 million individuals receiving an SBIRT service over the life of the grant portfolio and increasing the number of people engaged in treatment and recovery services. So now to kind of switch gears a little bit, SAMHSA is also engaged in behavioral health financing research, and this isn't really my area of expertise, but several of my colleagues are in the audience today and can answer questions that you might have based on our discussion here. And part of our strategic plan includes our research around behavioral health care and financing. And we provide large-scale analysis and technical assistance through our Center for Behavioral Health Care Financing and Innovation. And for the purposes of this, I want to take a look at some of our efforts around workforce incentives. Psychiatrists per 100,000 of the population declined by 10% between 2003 and 2013. Psychiatrists have lower rates of participation in insurance networks, as you were talking, Dr. Rainey, and compared to other professionals, further creating barriers to access. A 2016 survey documented a significant decline in insurance reimbursement for psychiatrists. For example, only 43% of psychiatrists accepted Medicare assignments, and the question for that was why? So studies that we conducted at SAMHSA Center for Behavioral Health Care Statistics and Quality, funded through the CFRI, analyzed the CPT coding changes, bundling of the EMI codes and psychotherapy, in-network and out-of-network reimbursement rates, and out-of-pocket payments and other elements of the billing for care. And what we found is that differential reimbursement may explain why psychiatrists are more likely to forego participation in insurance networks relative to other medical doctors, and that this dynamic can increase patients' need to go out of network to receive psychiatric services, resulting in higher out-of-pocket costs for the patients, thus leading to less utilization of those services by the patients. In the long run, differential reimbursement may be an important access barrier and long-term barrier to psychiatric workforce entry. These are important considerations to understand about the incentives of workforce development and ultimately access to patient care. I want to thank you for letting me provide this discussion at the very end of the day, and I wish I had a joke or something entertaining to say, but I don't. But if you guys have any questions, this is my information, and you can feel free to contact me, and if I don't know the answer, I'll be glad to get you to somebody in our agency that can help you. So again, thank you for the opportunity to share with you what we at SAMHSA are up to.
Thank you so much for that. So I am going to open up the floor for questions at this time. But before I do that, I want to kind of issue a challenge to our audience. We at CMS are very interested in addressing the workforce issues, and we understand a lot about the barriers to having a diverse and adequate workforce. What we want from our audience is any innovative ideas that they have on how to address these issues, including telemedicine, which is something that we touched on. But we're interested to hear what you have to say. And we're also interested in any ideas that our panelists may have that may be something of interest for us and help us kind of address these issues. So I guess we'll start. We're going to put Dr. Rainey's slide back up just for kind of a way for us to couch our presentation, but we'll also take questions from the audience. Okay?
Hi, Stuart Gordon. I'm Director of Communications and Policy with the National Association of State Mental Health Program Directors. We're the 50 mental health program directors in the states and actually also the 4 in the territories. We have filed some written comments, and we've suggested 8 different things that could be included in any delivery and payment system reform. But at the top of that list really is the use or getting Medicare to reimburse for peer support for older adults. You've got Medicaid reimbursing for peer support in 43 states. Medicare refuses to reimburse for peer support. There are some very good models out there of peer support workers working in transition in the hospitals and then following the patient into the community. You've got a great model in the Georgia Medicaid program where you've got the peer support workers almost working as a care coordinator for whole health. I was particularly unhappy that the coordinated care model did not include an opportunity to include peer support, because I think that would have been a great opportunity, and it's possible that peer support workers could work as care coordinators. NASPID brought together about 31 people, a lot of the people in this room, in a roundtable in April. We've done a white paper, we've attached it to our comments. But I understand that Medicare is very much more a medical model than Medicaid is, but I think there's some change going on there, and I think that if we really want to address the issues that behavioral health folks need to have addressed, we need to move away from a medical model. We need to look at supportive housing. We need to look at supported employment. So that's my rant, and I was just wondering if I could get some feedback from you all on that.
If I can just make one quick comment, and if I can just go back to my slide. One of the things that CMS did that I applaud them for is they did not assign a licensure level or anything. Where's this little red thing? I saw it earlier. To the gal in the red shirt. They did not say it has to be a licensed social worker. They did not say it has to be a licensed psychologist. They did not say it had to be a licensed professional counselor. And actually, a lot of the research going on right now is using paraprofessionals. The Diamond study has a great study that actually showed paraprofessionals, their PHQ-9 scores were equivalent. Don't tell the nurses this, to the nurses in the Diamond study. So I absolutely agree with you. And just so that you know, for clarification, CMS did not say. What they said was, this care manager has to have either a license like psychology and social worker or specialty training in behavioral health. I actually spent a lot of time going around training paraprofessionals to be in the red shirt.
That's great news.
So that's just one point of clarification. You could use them in primary care. You could also have, I've worked in Alaska where they've got community health workers. You've got peers out there. They can still be part of the team and share some of the pie from that $125. So they did not, and I applaud CMS for two things. They did not limit the diagnosis to depression. A lot of people think this is just depression. It's substance use, it's dementia. You heard everything today. And they didn't define who that specialist had to be. They said, but you got to train them to understand behavioral health and boundaries, all the things that are important. But I really appreciate your comments. I think NASHBID's great. We're working on the mortality gap with you guys.
Thank you.
All right, thank you.
Want to say something about payment around peers? Because you're doing it, aren't you?
So to look at workforce a kind of different way, you can imagine, so you have two people who are socially isolated, like living in adjacent apartments, let's say, and social isolation we know is worse than hypertension. And this is kind of for the payer, but for all of you as well. So you can imagine doing these coordinated programs where you have social workers deployed and doing behavioral activation and getting the people out into the community and getting unsocially isolated. But they could also just befriend one another, and that would also help alleviate the social isolation. You can imagine like a million similar sort of situations around like food insecurity in restaurants with extra food. How does payment models fit into the sort of like, when you mentioned family, community activation, how do we activate towards co-production of solutions using payment models?
Mm-hmm. So, and thank you for that. Thank you for that question. So, what I would suggest is, if there's any type of, so if you're looking to approach a payer, what my recommendation would be is, if there's a model that you have, assemble it, take it to the payer, and then it becomes even more important if you have any type of outcome data to help support the effectiveness of it. And then that is one way.
To addend it, I do not have a model. I was hoping you would.
Oh, in terms of, well, yeah, and that'll be for a longer conversation in terms of, what could be done. But in this case, for example, what we would do is, kind of like work with you to find out more about how we could be able to put those pieces together, and then to find out who would we focus on, what type of clinical profile, and exactly where geographically, and what are the other resources that are there, especially in areas, for example, if it may be a rural area where there just is not much going on in terms of a formal network, then something like that becomes even more important. So different variations, different things that we would need to take a look at, but it's a good question.
Thank you.
I'm vertically challenged and I didn't know it. My name is Elizabeth Faust. I'm a behavioral health medical director from Blue Cross Blue Shield of North Dakota. And Daryl, Jackie says to tell you hi.
Oh, great.
So one of the things I wanted to do was to tell Dr. Rainey that there actually are psychiatrists who go to North Dakota, because I am one of them. And there are private payers who have opened up the collaborative care codes. So what I wanted to say was that this morning, I think Patrick Kennedy sort of sent out a call to action, and he said, payers need to pay and providers need to measure. And so I hear back and forth today, it's this side of the aisle's fault, or it's this side of the aisle's fault. And in reality, it's everyone's work. Because what we've done in my plan is I went to the dark side from the provider world after working a long time in the public sector and in the private sector, and I figured out you can't change the system until you change the reimbursement. Right. And so we're really working hard to build out the continuum, because we believe if you build it, they will come. But to this point about the workforce development, I think with psychiatrists in particular, if you build it, they won't come, because the current workforce is, I think, fundamentally not prepared to do the kind of work that you, Dr. Rainey, described, which I wholeheartedly agree, because we have to teach a man to fish. Because psychiatrists cannot, we can't play golf anymore, we have to play baseball. Care is a team-based sport now, and I think we have to begin to build into graduate medical education and retraining psychiatrists into these models of care, and to figure out how to pay physicians who will do collaborative care like your model better than we pay them to do private practice where they treat less ill patients. So redesigning reimbursement, but also holding the provider community accountable. The other thing that I wanted to say about this is that from the payer side of the equation in the commercial world, I think there's a lot of difficulty with the idea of paying for things that have traditionally been thought of as part of the kind of the outcomes of social determinants of health. And I think, Daryl, you really spoke to that because you're trying to figure out how to use the community sector models, which understand that very deeply, and pull those over. But I think the more that that providers can work to outcomes, to define specific models, to define specific things that they're doing, and to involve non-traditional workers, such as peer recovery supports and peer recovery, sort of moves beyond our traditional medical model, but we have to do that to sort of build out kind of the whole team and have everyone work to the top of their license or not. So that's all I had to say.
Thank you for your comments. I want to make just a quick, another kudo to CMMI, right, because we keep doing that today, but they have quite a few TCPI grants out there, and so the American Psychiatric Association got one of them to train 3,500 psychiatrists to do this. So, and I went to Fargo. I'm a trainer. Actually went up to Fargo and did the training for the North Dakota Psychiatric Association. So I know where you live. I know there's a few psychiatrists up there. They came to breakfast. But so we're trying to retrofit us old folks. I think I'm part of that aging population of behavioral health people. I won't tell you how old I am, but if you think about those numbers, I think I'm in that group. But we're trying to retrofit the people like me and you that are already out there, and then residency training programs across the country are being asked, what's your strategy around integrated care? And there are actually even fellowships now in it. So residency training is 10 years behind, so we're spending a lot of time retrofitting. Because this was a CMS grant that the APA got, those modules for training psychiatrists and now PCPs are actually on the APA website. So people can do them for CME credit.
Okay, thank you. So we have about 6 more minutes of question and answer time. We have a few people in line. So I just would ask that you keep your questions a little bit brief, and so we can make sure we get everyone's perspective.
Thanks for taking my question. Can you hear me? I'm a clinical psychologist. I work in a state-run long-term care facility, and can you hear me? Oh, sorry. I'm a clinical psychologist. I work in a state-run long-term care facility, and we're doing our best to address some pretty significant needs with dementia behaviors and also some serious mental illness concerns that we have in our community. And because of some budgetary things going on, we don't have a psychiatrist anymore. And so I'm just wondering if you have any creative ideas that we could pursue to get some of these met.
So, I mean, I would say a couple things, and I have people in the audience, we've been talking about this at the breaks and stuff today, but one of the things you heard from the Alzheimer's group today is there's 4 trials out there of the collaborative care model, which includes a psychiatrist as part of that team. So a lot of that work you're doing in long-term care in the skilled nursing facilities can be billed as long as you meet the, the requirements of the codes. That's one thing. And the second thing that's going on is in the telepsychiatry field. There are a lot of people that do geriatric psychiatry, and I don't know if your budget thing means we can't even hire a telepsychiatrist, but they're actually beaming into the nursing homes and doing telepsychiatry in the nursing homes. If you get a psychiatric nurse practitioner, they're a little bit cheaper. Those are my, I don't know if you guys have any other thoughts, but that's how we're trying to address the psychiatric piece in long-term care.
Okay. Thank you.
Hi, I'm Jake Jackson, and I'm here on behalf of the National Board for Certified Counselors. We're the national credentialing organization for over 64,000 nationally certified counselors. And I'd just like to thank CMS for putting on this meeting. I think it's been a wealth of information. I'd just like to ask what the panel's recommendations would be for addressing the shortage of mental health professionals that are currently available to Medicare beneficiaries in particular. Counselors, for example, are not covered under Medicare, so I'm just curious as to whether you think that adding more types of providers to Medicare would be a viable solution to this problem.
Yeah, so it sounds like that's similar to a question that was raised earlier, so I would say that's more of a CMS type of question for them to be able to address. But, yeah. So
I mean,
I
my
would have to
answer,
defer.
my answer is absolutely.
Sure. Okay.
LPCs, licensed family, marriage and family therapists.
Thank you.
We're interested in workforce. Thank you.
Thank you. I'm Bill Whiteley. I represent CHE Behavioral Health Services. We're a specialty practice that focuses only on long-term care. We provide behavioral health services in long-term care settings. And I had a question for Dr. Rainey about the application of the collaborative care models in long-term care. We think this is the perfect patient population for this. 50% of the residents in a long-term care setting have comorbid medical and mental health conditions. 20% of them are going to be readmitted to the hospital in the current year. And we think, and there's a measurement system built inside of every nursing home, the MDS measurement system, so we can constantly track our progress with these patients. We think it's the perfect setting for collaborative care, and I wanted to get your thoughts on that.
I absolutely agree, and you actually heard from Dr. Bustani. I don't know if he's still here, but you heard from him earlier. There are 4 trials in the use of the collaborative care model for Alzheimer's. The only thing you have to remember is the PCP drops the bill. So the collaborative care code has to be attached to a PCP's NPI number and billed once a month. So if you've got 40 PCPs sending their patients to a nursing home, they may not be that interested in whatever this thing is you've got going on in the nursing home. So you do need sort of a central PCP who's willing to have that code attached to them. But I see no reason why you can't do this in a nursing home.
We think the setting's perfect, the patient population's perfect, and there's really 2 technical issues. One is the fragmented behavior, the fragmented primary care that you mentioned. And then the second is that for these collaborative care codes, because it's a facility setting, there's no PE RVU. So there's no money for the care manager. And so we've approached CMMI and CMS to talk about, hey, let's just try to make sure that there's PE RVUs in the facility setting, because that money's there for the care coordinator. And without the care coordinator, these models, as you know, these models just don't work.
Well,
all right, thank you.
Thank you for that. So I do want to, for these last 2 presenters, or 2 questioners, I actually want to make a plug for our email address, the CMMI Summit at Ketchum. It would be really great if you guys could write those things up and send it to us, because that way we can address it in a more systematic manner. We have about 1 minute left, but we want to get both of the questions in, so brevity is the word of the day.
My name is Catherine Venny. I am a clinical psychologist in Pennsylvania in private practice, not representing anybody but myself. I am very concerned about the retrofitting of the workforce, which Dr. Rainey brought up. Having been a clinical psychologist for 36 years, went back to Arizona State for complete retraining in integrated behavioral health. That's great, except the only thing I can really do with it and bill for is my own private therapy. I can't even bill for expert services, which I do every day of the week. And also, I think with Medicare today, we have a very large workforce that we are not utilizing. I learned in Pennsylvania we have 840 master's level licensed psychologists who cannot bill Medicare. So I think we really need to do something to promote the use of people we already have in the workforce to their highest level of licensing. I had a woman call me the other day for therapy in my private office. The first thing she said was, I don't want to see someone my daughter's age. She is an older client. So I guess my plea is, can we get more codes released and more broader reimbursement for workforce people that we already have?
All right, thank you. We'll take that. Last but not least.
Sure. So my name is Afia again. My question has to do with how to help a patient recognize who a good or a bad psychiatrist is, because this is really a true story where a patient once went to see a psychiatrist and complained that, you know, he or she had a tightness at the top of their head or at the bottom, and the psychiatrist's response was, did you wash your hair? And this is not really to bash, you know, psychiatrists. I really appreciate the work that they do, but what are some of the criteria, you know, someone could look to be able to decipher the differences? And closely related, a lot of my reading suggests that there's now increasing support advocating for, you know, brain scans as a way to improve that condition. What are your thoughts on that? And I know it's the last question. It has to do with health professionals who are at the very bottom of the chain. You know, usually when incentive programs are discussed, it's usually about doctors, nurses, and, you know, people that are above. But there are also people like the home health aides and the certified nurse and assistants who are usually bashed that it's, you know, they are either abusive, you know. So maybe we can look at incentivizing the payments, not just for those at the top tier, but also people that are at the bottom of the ladder.
Thank you for your comments. We're kind of running out of time, so we might not be able to address them. I apologize.
No, it's fine.
Do we have a couple minutes? Do we have a minute? So we have a minute if our panel had anything to add.
Yeah, so just to address the question that you had raised about making sure that a provider that you're looking to see is similar in terms of makeup, cultural sensitivity, to really to be able to address the needs, you know, of that particular member or patient. So in a provider's network, they have a directory, and it's very specific in terms of the types of specialties that they have, but even to race, ethnicity, and even languages spoken, to make sure that there's a good match to be able to speak with a provider that has a similar culture or background or a shared commonality. So that would be the first thing I would do to suggest that, is check out the directory that you would have access to for your providers. I also know there's a national directory out there through Psychology Today that has a very granular list of specialties of providers that take all of those things into account to make sure that members are matched up with providers to meet their needs.
Okay. What of the incentivized payment at those that are at the bottom of the occupation ladder? Anyone had thoughts?
So can you help me understand more about what you would be looking to incentivize payment towards?
For people like CNAs, you know, I know some people have been in that workforce for past 15 years and, you know, their salaries don't increase. The last time I checked, there's a law that also says that they're not supposed to work for more than, I guess, 40 hours, but then it kind of created, you know, this other scenario where the agencies are now pulling back. They wouldn't have them work for, let's say, more than 36 hours because they don't want to do, like, let's say, overtime pay for them.
Mm-hmm. And yeah, that's a larger challenge in terms of what happens there.
Yeah, I mean, I think we're interested in innovative solutions, and we're interested in your thoughts on it. So if you, again, a plug to the email address, you write it up, and it'll be something that we can kind of look into. I just want to thank the audience for the great questions and the great ideas. I want to thank our panel, and so I'm just going to bring up Chris to introduce Amy. Thanks.
All Hi, good afternoon. I'm Amy Bassano. I'm the Deputy Director of the Innovation Center, and thank you all for coming today. Started the day out this morning back in the green room back there with Dr. Klein listening to Patrick Kennedy, and we were laughing about how he's such a tough act to follow. And I think Dr. Klein did a great job following him, but the thing that really struck with me is all the acts that followed today and all the energy and enthusiasm and excitement and passion and great ideas that people have brought to these really sticky, hard, but vitally important topics. And so thank you all. Thank you most to my team for putting this fabulous event together. Thank you to all of our speakers for sharing their thoughts and time and energy and putting these presentations together. It really means so much to us, and to all of you for coming and traveling and being with us here today. This feedback has been really amazing, and so people are probably wondering what's next. And so I think it's been mentioned over a couple of times today, but just to be clear, we're going to take in all of this information and digest. It's going to take a while to sort through it because there are so many different threads of ideas going here, and then use that to potentially develop innovation center models to address these key problems. And that can come in many different forms about what that means in terms of a model and what we can do. Many important issues raised here today are the Innovation Center Authority specifically has certain limits, and so we can think about what we can do here. But I think one of the important things that coming out of this is the partnership we have with our sister agencies across HHS and others in the states and in the communities, and we can think about creative ideas about how we can solve problems even without a model, because I know Chris and I have been talking about things we can look at. Well, what can we talk to, people across CMS or other places to try and address some of these very specific things and what we can do within our center authority. So lots of homework for us. Again, the email address isn't up there, but I think you've been seeing it all day for any other remarks or comments you want to add in there. And I think that for that concludes our really wonderful session today. A big thank you again to everyone for coming, and please have a good trip home and have a nice weekend. Thank you.
Thank you. Nice meeting you.
Yes, hang on, I'll come down your way, or one of us is going to probably fall down these stairs, maybe me.
No, please don't fall.